I do want to get into the other issue, and that's about the abnormal test. So the patient is taking a compound, it doesn't show in the urine. The patient is taking compound and a metabolite of that compound that should be there isn't there. A drug that shouldn't be there, an illicit drug is there, a drug that is a prescribed drug that this patient doesn't get is there. So there are all sorts of machinations on what could show up in the urine. You all know this. But my question is, how do you confront, how do you discuss that with the patient, knowing there's uncertainty about it, that we don't always know for sure? Is that cocaine there because the patient took cocaine, or is it some other compound they use because they have a cold and that contaminates the test? How do we know for sure, and how do you tell the patient about it? So I'm interested. Michael, why don't you give me your idea of how you do that?
I start out by saying that I've gotten a result that's inconsistent with what I was expecting. And I tend to be more quiet at the beginning rather than talk a lot, because I do believe that it's a little bit like your mother used to tell you when you were small, that the person who's actively lying to you will not be able to sustain a coherent and consistent conversation about why this has occurred and what's happened, and the story will begin to fall apart from its own weight. On the other hand,
that sounds like a psychiatrist talking, but keep going, keep going.
I think that the other part of it, though, is that I really am curious as to what the patient will say or do when I present them with my puzzlement over how this could have occurred. And I think it's important to see how the patient reacts, what kind of explanation they give you, or whether or not they really have no idea what you're talking about. I think that then I enter a phase of saying, well, this is what the test showed, this is how it could be interpreted, and I'm concerned that this result has come back because it indicates to me that something's not going well, and therefore we need to get to the bottom of that. And what ideas do you have for how this occurred? Or, you know, this is what I think is most likely going on given that I've taken care of you for some period of time. And you see where the conversation goes. At some point you have to reach that decision, as you say, of confrontation, where you say, if this happens again, or this is what I think is happening, so now we're going to have to increase our scrutiny. My concerns about you mean that you need more care rather than less care. And we're probably going to have to involve some additional resources or additional people to help us understand how to make sense of this.
So one of the things I want to make sure I point out here is that you have the conversation. You don't necessarily discharge them from the practice.
No.
You don't even stop prescribing necessarily. You
Correct.
may, certain circumstances you may, but you get more information and you certainly tighten up whatever you're doing with the patient. You may see them more often. You may give them smaller amounts. You'll test their urine next time. So there's certain things that you do, not necessarily cut them off.
Right. They are on your radar screen now.
Right.
The thing that you have to differentiate when you get an unexpected result back, don't hesitate to call the lab to help you interpret the lab results. And use the lab as a resource and the head of the lab as a resource in regards to interpreting an unexpected result. And remember, with patients, separate what you think is going on from a medical problem from a criminal problem. Diverting the medicine is a criminal problem. Abuse, misuse, addiction, binging is a medical problem. And you could always fire the molecule without firing the patient and try to get them on track, and then at some time in the future, if necessary or indicated, place them back on the fired molecule, meaning the opioid.
I have a little bit different look into how to deal with this. Some illegal substances I will not give a second chance. And I'm going to talk now from a primary care perspective, not from a specialist perspective. Primary care is a very busy practice, and they have a lot of things to take care of the patient. Opioid and pain is one element of what they deal with the patient. If this is going to take them so much time to solve, it is time for the patient to go to a specialist. But if in an area where there's no specialist, and some primary care, we know this, when illegal drugs show up, for me, as a primary care, if I'm a primary care physician, this is it. I am not going to give second chances. Cocaine and heroin, I will not give second chances. This is beyond my reach. This is beyond where I can help them.
They may want to put in methamphetamine as well.
Oh, methamphetamine, exact. So like, I mean, all the illegal drugs, ecstasy or whatever it is. So they need to go to a drug rehab center, whether it's close to their house or away from their house. This is it. The other part is, which is I concur with Howard, is that I will continue to care of your diabetes, I will continue to care of your hypertension, but I will no longer care of your pain. And because we had something going, you violated the agreement, I am done. Even if you have to drive 2 hours, even if you have to drive 3 hours, this is your own doing. It's no longer my responsibility. Now you need help from a subspecialist rather than me. This is how I would approach it.
Let me make 2 quick points about illicit drugs. One about cocaine. It won't come back cocaine positive. It'll come back positive for its metabolite benzoglycanine, which is readily picked up by point-of-care testing. So that's one point. The other point to make is that I'm using the urine drug test, again, for the benefit of the patient based on mutual trust and honesty. And I have to know what the capability, again, of my lab tests and what I will pick up and what I will not pick up. And I will not pick up heroin on a drug test because heroin has a short half-life of 3 to 5 minutes, but I'll pick up its end metabolite, morphine. So the clinical pearl is if you have a patient, whether you're a primary care doctor or a pain specialist, and there's a history of heroin abuse or addiction, morphine would be a poor choice to use because when the morphine shows up on the urine drug test, you will not know whether it's from illicit heroin and its metabolite or from your prescribed morphine.
I don't want to underestimate the difficulty this is for us in primary care because I have to confront my patients as well with the urine test. But I think we heard some very useful comments here on how to start the conversation and how to deal with the drug test that comes back and it wasn't what you thought it would be. But I think the underlying comment is you just can't leave it alone. Not doing the testing is a disservice, and ignoring the lab result, the test result, which I see frequently in primary care, doesn't do a good job as well at all. It's not good for the patient's health. It's not good for your practice or society. I want to thank the panel very much for this interesting discussion.